Good afternoon. Today we're going to discuss the hematology component of anemias. So basically, what is anemia? Anemia is a decreased number of total erythrocytes in plasma and also decrease of hemoglobin concentration. Um, in addition, volume of red blood cells that caused by a variety of factors. So you could have anemia due to blood loss, to bone marrow failure, to impaired production or hemolysis, including destruction of erythrocytes. So the most common causes are decreased production, acute or chronic blood loss, increased cell destruction or hemolysis, or a combination of all these factors. Remember that red blood cells production is called erythropoiesis that takes place in the bone marrow under the control of the erythropoietin. In the absence or when there's diminished um, oxygenation. Juxtaglomerular cells as well in the kidney produce erythropoietin in response to hypoxia and increased levels of androgen. In addition, red blood cell production requires adequate sulfates or substrates. So when you have iron deficiency, vitamin B12, or folic acid deficiency, also the RBC production or erythropoiesis is affected. RBC, remember that it survives in 120 days. They then lose their cell membrane and are largely clear from the circulation by phagocytes or macrophages in the spleen, liver, and bone marrow. Hemoglobin, remember that is broken down into the cells of the hepatocytes by the composition of bilirubin. So there's degradation of the heme component of the erythrocyte to bilirubin. So when patients have hemolysis, you're going to see that they have hyperbilirubinemia and jaundice as well. So there are several enzymatic steps that take place to be able to reutilize the erythropoietin and continue erythropoiesis functioning. There is a maintenance of a steady number of RBCs required daily, so there is renewal. So you would see that when there is the exhaustion of the bone marrow, either by acute episodes of anemia or bleeding, you would see an increment of immature RBCs, which are called erythrocytes. So low levels of androgens are also associated with decreased erythropoietin level in women and men, and mostly in elderly population. This predisposed to anemia as well, as does the decline in the capacity of the bone marrow to produce RBC. With aging, since we also have to speak about gerontology, hemoglobin and hematocrit decrease slightly, but not below normal levels. In women, other factors that frequently contribute to lower hemoglobin and RBC levels are the menstrual blood loss and also the increased demand for iron due to multiple pregnancies. So let's talk about first laboratory values. You need to be very familiar to the laboratory values in order to distinguish the different types of anemia. You have the hemoglobin that in males is 14 to 18 grams per deciliter. For females, because of the menstruation, 12 to 16 grams per deciliter. The hematocrit also varies by gender. It's 40 to 54% in males and 37 to 47 in females. Remember that ferritin and transferrin are mediums of storage and transportation of the iron in the iron metabolism. The ferritin normally is greater than 10 in women and more than 20 in men. You would see when patients have iron deficiency anemia, the ferritin and transferrin, which are the storage and the transportation capacity and saturation of the molecule of iron, will be decreased. In the contrary, total iron binding capacity will be elevated when patients have iron deficiency anemia because since there is no mediums of transportation, the capacity of this transportation mechanism will be saturated. So in other words, if you have a bus, I always make this example, if you have a bus of 40 seats and only 20 passengers, meaning that there is decreased capacity of passengers amount. So if it's 40 seats and 20 passengers, the bus will be plenty or would have plenty of room for for binding. So therefore, when there is decreased amount of iron or molecules of iron available for erythropoiesis, the capacity of binding of the transport medium would be increased. On the contrary, if you have iron overload or you have hemochromatosis, which is an iron saturation elevated by toxicity, is backwards. You're going to have ferritin and transferrin, which is a storage and transportation mechanism, elevated, and the capacity of that bus, having only 40 seats and 100 passengers, would be saturated. So the total iron binding capacity would be decreased. It's a little backwards. Serum iron would be 50 to 170 micrograms per deciliter in a normal person. You have the mean corpuscular volume that would tell you the size of the red blood cell. So normally you have 80 to 100. If it's less than 80, you have microcytic anemia. If it's 80 to 100, you have normal, because that's the normal value, normal cytic anemia. And if you have greater than 100, you have macrocytic anemia. Then you have the mean corpuscular hemoglobin and the mean corpuscular hemoglobin concentration, which this one is the one that you have to concentrate on. 32 to 36 will give you the actual color or chromacity of the red blood cell. If it's 30 to 36 is normochromic. If it's less than 32 is microchromic. If it's higher than 36 is macrochromic. But the problem is that when you have a big cell, which is a megaloblastic cell or spherocytosis, the amount of color that is distributed in that giant cell would be spread evenly. So therefore, macrochromic anemia does not exist. So the basic combinations for anemia would be normocytic normochromic, so normal with normal, microcytic hypochromic, which is low cell size with low color, or macrocytic big size with normal color, because remember, the bigger the cell, the higher the distribution of color or chromacity among or pigment among those cells size. So therefore is evenly distributed, and macrochromic does not exist. So you would say macrocytic normochromic. So again, ferritin, remember, is basically storage of the iron, okay, and is also an acute phase reactant. It is elevated in the presence of iron sequestration from bacteria or iron overload. If it drops, then you're in the presence of iron deficiency anemia. The serum iron basically measures the free iron in serum, and total iron binding capacity is basically the indirect measure of transferring, which is a transport mechanism that holds the iron in the serum. And I already explained how does it work in saturation component. Okay, so basically, what are the most common in general of anemia and the common types that we kind of discussed already? Remember that you have hemoglobin 14 to 18 in men and 12 to 16 in women. So if you're in the presence of a low hemoglobin and low hematocrit, then you're going to measure reticulocyte count. Okay, remember that reticulocyte count is the measurement of the immature cell, meaning that the bone marrow is healthy enough to produce immature red blood cells and is working properly. Okay, so you have different type of anemias. You have when the MCV is low, when the MCV is normal, or when the MCV is high. Remember that MCV is the mean corpuscular volume that tells you the size of the hemoglobin. So if it's low, you're in the presence of microcytic anemia, and the two most common types of anemia that we'll discuss here today for microcytic hypochromic will be iron deficiency anemia and thalassemia. Then you have when the MCV is normal, which is normocytic normochromic. The most common illness that is in the presence of normocytic normochromic anemia will be the anemia of chronic diseases. In addition, if you have an acute blood loss, you would be in the presence of a normocytic normochromic anemia. On the contrary, if you have a chronic blood loss, which is most commonly from the GI tract, you would be in the presence of microcytic hypochromic. In addition, for the normocytic normochromic, you have anticonvulsive drugs, antiviral, tumors such as leukemia, lymphomas, infections in the bone marrow. You would be all the chronic diseases that you can think of. Renal failures here, um, any type of disease that is basically chronic, including myelodysplastic syndrome. When the MCV is high, which is macrocytic normochromic, you would be most commonly in the presence of either folic acid deficiency or vitamin B12, which are the two most common. In addition, you have to think about alcohol abuse. So all those patients are alcoholic and they have liver cirrhosis. Patients that are having chemotherapy, even though chemotherapy could be also as well normocytic normochromic, and many other medications that would also be discussing here today. I put this slide because it's very important to remember how bone marrow differentiates. And as we yield or the bone marrow gets deficient, or if the bone marrow is activated, accelerated function, you would find more immature cells in plasma. For example, in order to form the erythroblast, the hemocytoblast, which is the the mother cell, converts into proerythroblast up to maturity, which is erythrocytes losing their nuclei. Then, in order to obtain the granulocytes, which are the basophils, eosinophils, and neutrophils, remember that these are the myelocyte lineage. You would get progranulocytes, and then mature cells will be basophils, eosinophils, and neutrophils. Then you have the lymphoblast to lymphocyte lineage, which are the agranulocytes. That this is one of the explanations why in patients that have lymphomas and leukemias, you would see more often presence of blast, which is the more immature form of the agranulocyte or lymphocyte lineage. So you would have lymphoblasts or monoblasts. And also for the thrombocytes, which are the platelets, as the bone marrow gets activated or diseased with myelodysplastic problems, leukemias or lymphoma, you will be able to see more megakaryoblast or megakaryocytes. In addition to that, before in the erythrocyte part, if you come this way, in the erythrocyte part, before erythrocyte formation, you would have another immature cell, which are called reticulocytes. So whenever a patient is bleeding profusely, or when the patient has anemia of acute diseases, if you check the reticulocyte count, is an indirect way of knowing that the bone marrow is healthy enough and is functioning properly. This is the same thing that I already explained. So if you could see here all the immature cells, and before the formation of the erythrocyte, after losing its nucleus, you have the formation of the reticulocyte. So measuring the reticulocyte count is a way of knowing that the bone marrow is healthy and functioning properly. So reticulocyte count normally is from 0.5 to 1.5%. Now, we also will discuss other components that will tell you that there is tissue breakdown, meaning that when this is present, you must suspect that there is hemolysis or breakdown of red blood cells. So basically that the anemia is not produced by either iron or folic acid or vitamin B12, but it might be happening by hemolysis, by rupture of the red blood cell. And this is by measuring bilirubin, by measuring also LDH. LDH is not only sepsis, a parameter, is also a measurement of tissue breakdown by the anaerobic metabolism. and haptoglobin as well. I don't know if you have seen in clinical practice, hematologists being requesting haptoglobin in plasma in order to understand the mechanism of effect of or etiology of this anemia. So you're going to see bilirubin, you're going to see LDH, you're going to see haptoglobin as well as reticulocyte count. If you remember in bilirubin, which is another slide of this PowerPoint, bilirubin is basically a breakdown product of the heme catabolism. It's caused by the body's clearance of H red blood cells, which contain hemoglobin. Bilirubin is excreted in bile and urine. So after bypasses the liver, you will excrete bilirubin in a form of stercobilin by the feces and also urobilin by the urine. So basically, this diagram is important because if you have elevated bilirubin, you would like to determine if this is coming prehepatic, intrahepatic, or posthepatic. And it's very, very easy to understand. If you have prehepatic, you just have to remember what gives blood supply to the liver. So what gives blood supply to the liver is basically the hepatic renal artery and the sinusoids to the hepatocytes, which are the cells in the liver. So where is the hepatic artery coming from? It's coming from the red blood cell, it's coming from the capillary, from the vessels, but it's also coming from the heart, right? It's a branch of the aorta. So having any cardiovascular diseases, having any capillary or vascular problems, and also having hemolysis of the red blood cells would give you prehepatic hyperbilirubinemia, which is no more than what's called unconjugated bilirubin will be elevated or indirect bilirubin. So those are the causes of prehepatic hyperbilirubinemia. Then after that, after the bilirubin is combined to the albumin, is transported into the liver and is conjugated by glucuronic acid. So any intrahepatic liver disease, and that relates to cirrhosis of the liver, hepatitis in the past, hepatocellular carcinoma, as well as whatever connection the liver has with other organs, for example, to the gallbladder, having um, cholecystitis or cholelithiasis, or cholelithiasis, or to the pancreas, pancreatitis, or to the duodenum, duodenitis. So all these diseases will give you conjugated hyperbilirubinemia or direct hyperbilirubinemia. In addition to that, we have the breakdown or more conjugation of bilirubin before it's been excreted into the feces or into the urine by bacterial protease. So any problem in the intestine, having colitis, including bacterial C. diff colitis, or any cancer in the colon, um, or any portal vein obstruction, can give you conjugated hyperbilirubinemia as well, uh, which is the same thing as direct bilirubin. Okay, so if you look here, even though this looks very complicated, is very, very easy to understand. So if you have prehepatic, which remember, it comes from the vessel, it comes from the heart, from the capillary. So think about any disease process that can lyse the erythrocyte and destruct the integrity of the erythrocyte. And that is sickle cell crisis. That's a hemolytic type of anemia. Any drug that could lyse the erythrocyte, any type of hemolytic anemia, including GP60 deficiency, blood transfusion, excessive amount. So that would be unconjugated hyperbilirubinemia. Then you have intrahepatic, that it says it could be extensive burn, surgeries, diabetes, drugs, neoplasm, cholecystitis, cancers of the pancreas, pancreatitis, obstruction of the common bile duct. Uh, that would give you as well, in addition, cirrhosis of the liver, hepatitis, cholangitis, pancreatic carcinoma. Uh, Basically, that would be intrahepatic or posthepatic, and mostly obstructive. Intrahepatic as well would give you any damage of the erythrocyte. If you look here, hepatitis, cirrhosis of the liver, hepatocellular carcinoma, as I already discussed. Okay? Now, in addition to that classification that we talked, so the most common is what we already discussed. In addition, we have a kinetic classification. So either if you have a hyperproliferative um, anemia, type of anemia, or if you have ineffective erythropoiesis, or if you have hemolysis, or if it's due to bleeding. For example, if we're going to discuss briefly hyperproliferative anemia, which is a type of kinetic classification, is a result from deficiency of erythropoietin. So if you look at that classification, it's very, very similar to the normocytic normochromic type of anemia that relates to chronic diseases. If you think about renal failure being a chronic disease, this is a disease that has deficiency of erythropoietin because the juxtaglomerular cells of the kidney are damaged. Okay, so it could be metabolic, it could be endocrine disorders as well. Okay, anemia of renal diseases are the most common, but in addition to that, you could have amyloidosis, diabetic nephropathy, um, in this type of disease process. In addition, you would see in class that patients that have TTP or ITP, immuno thrombocytopenic thrombotic purpura or idiopathic, could also have this type of disease as well. The diagnosis of hyperproliferative disease is basically based on the demonstration that the patient has a renal insufficiency or the diseases that we already discussed, and this is a normocytic normochromic type of anemia. And the therapy is directly based on to treat the underlying condition and to supply to the patient the erythropoietin drug. Okay, so this is what I just discussed right now. So in addition, includes anemia of chronic diseases. Even though it says iron deficiency anemia, this is not the most common way of presenting hyperproliferative anemia. Normocytic normochromic is mostly for chronic diseases, for aplastic anemia, okay, for poisoning lead, renal disease. So basically it marks most commonly renal failure and anemia of chronic diseases, which include that one. In addition, thyroid diseases and nutritional diseases as well. If we're going to discuss, for example, aplastic anemia, which is a type of hyperproliferative anemia, um, remember that aplastia means no production. So there is it's also a normocytic normochromic type of anemia that results from a loss of blood cell precursors, so causing hypoplasia of the bone marrow. So patients are going to have anemia, they're going to have neutropenia, they're going to have platelets diminished as well, thrombocytopenia. The etiology, most commonly in adolescent, is idiopathic. Okay, but other recognized causes are benzene, radiation therapy, anti-neoplastic drugs, antibiotic, anticonvulsants, etc. Here you also have the anemia of Fanconi disease, which is very, very rare, is familial, is also includes bone abnormality. Patients have microcephaly, hypogonadism, brown pigmentation of the skin. It occurs in children with abnormal chromosomal deficiency. Okay, symptoms for aplastic anemia is insidious, so often occurs over weeks and months after the exposure of a toxin. Uh, Signs could be from pancytopenia, all the signs and symptoms of anemia. Patients might have severe thrombocytopenia that causes petechiae, ecchymosis, bleeding, agranulocytosis with life-threatening infection. Patients will have splenomegaly. Very difficult to discern the difference with the leukemias and lymphomas. Basically, aplastic anemia is suspected in patients, particularly very young patients with pancytopenia, when they have a WBC less than 15,000 or platelets less than 50,000. Okay, and the treatment is basically you give anti-thymocyte globulin, cyclosporin, or corticosteroids. Now, let's talk about the most common type of anemia, which are the most important for your clinical practice. The first is the microcytic hypochromic anemia, okay, that we're going to discuss here today: anemia of chronic blood loss, anemia of iron deficiency, and thalassemia. Okay, so remember, those are the three most common. You have iron deficiency anemia, which is the most common cause of anemia in the world. Okay, that results from chronic blood loss. And every time you have a patient with iron deficiency anemia of microcytic hypochromic type of anemia, the first and number one cause that you must rule out is GI bleed. GI bleed of chronic GI bleed. So therefore, you should do a stool cord blood in that patient. So in addition, do you have any type of chronic hematuria or manipulations of, gynecological or urological? Remember that the iron is distributed in an active metabolite, and total body iron is like 3.5 grams in a healthy person. So it's absorbing the duodenum and the upper jejunum. Absorption of iron is determined by the molecule and by other oil substances as well. Remember that in collaboration with other food and gastric secretions, acid gastric secretions, the iron is transformed from the ferrous to the ferric. Um, Also, in addition, the iron could be reduced absorption if the patients ingest certain food products such as vegetable, uh, tea. Um, so you see all the when you go to Chinese restaurants that you drink tea with your food, that's not good because the tea binds the iron molecule. And the reason why they put a lemon in your steak is because you need to transfer the molecule to the ferrous, which is the more absorbable. In addition, antibiotics such as, for example, tetracycline will decrease the absorption of iron. Okay, for iron to be transported in the intestinal mucosal cell is transferred to transferrin, an iron transport protein that is synthesized in the liver. Transferrin can transport iron from cells such as the intestine and macrophages to specific receptors. So from heme synthesis, transferrin transfer iron to the erythroblast, okay, and the transferrin is reutilized. The storage, even though the iron not used for erythropoiesis is transferred by transferring an iron transporting protein to the storage, which is called hemosiderin, and ferritin participate. So you need the storage in case of an emergency or usage in case the patient has iron deficiency anemia. So the main etiology, again, as we discussed, is when the patient have dietary iron diminished, so diminished ingestion is the first and most common cause, along with chronic blood loss from the GI tract. In addition, menstrual period, any vitamin C deficiency, because remember, vitamin C is an acid that is needed to transfer the molecule from ferric to ferrous. Then we're going to discuss thalassemia and as well chronic blood loss. Okay. So for the childhood, the most common are iron deficiency anemia and thalassemia, and for the adulthood is iron deficiency anemia, sideroblastic, even though it could occur in childhood, as well as lead poisoning, and vitamin B-C deficiency, that is a cofactor for the iron to be absorbed. Okay, so what are the most common values that you would see in iron deficiency anemia? So basically, look for the signs and symptoms first, okay, which are the same for the others. Fatigue is loss of stamina. You have shortness of breath because every time you have anemia, the patient could complain of shortness of breath because the hemoglobin transport the molecule of oxygen. They could complain with weakness, dizziness, pallor. That applies to all the types of anemia. In addition, what do they have specific for iron? They have pica. Pica is an abnormal craving to eat substances such as ice, dirt, pain. Other symptoms that could be present in all of the anemias could be concave nails, which is called koilonychia, dysphagia, because they develop esophageal webs, glossitis, cheilosis. So, what will you see in the laboratories? You're going to see a low hemoglobin. You're going to see a low hematocrit. You're going to see a low MCV. Remember, the mean corpuscular volume will be low, microcytic. You're going to see a low mean corpuscular hemoglobin concentration, less than 32, hypochromic. You're going to have a low RBC. You're going to have a low serum iron. You're going to have a low serum ferritin, but you're going to have an elevated total iron binding capacity. Remember, the bus is having 40 seats with a very low iron, which are the passengers. So you have 20 passengers and 40 seats, so you have plenty capacity for saturation. So the saturation percentage is diminished. So therefore, the total iron binding capacity, so the capacity of the bus to admit more passenger is elevated because you still have 20 more seats to occupy. Okay, so diagnosis, basically you do this laboratory test. Okay, and then how are you going to treat? Basically is by giving the iron that is diminished. So that can be provided as ferrous sulfate, gluconate, furamate. Um, Remember that food or antacids may reduce the absorption. So take it with an empty stomach. Okay. All right. So in addition to that, you could take the iron with vitamin C or any juice that contains vitamin C. In addition, you should tell the patient to eat high iron food products such as raisin, green leafy vegetables, red meat, citrus product, any iron fortified bread or cereal. Okay, so all the causes of iron deficiency anemia, even though we already discussed the most common, remember, most common, decreased ingestion and GI, chronic blood loss, no acute blood loss, chronic blood loss. Okay, so in GI, any malignancy, any peptic ulcer disease, are you taking NSAIDs, or any irritable bowel syndrome or inflammatory bowel disease, any low absorption because you're taking the wrong foods. This is the treatment that we already went over. So in addition to that, you have what's called iron toxicity. Iron, remember, that is um, absorbed by the GI tract. Okay, so once the GI tract has met its saturation, it will go into the blood. So patients that have toxicity for iron most commonly are children, so you don't have to worry mostly about this. But whoever ingests a large amount of iron pills can get toxic, and this start with the first most common sign is stomach pain in the epigastrium because it produces a severe gastritis with bleeding, metabolic acidosis, all the signs and symptoms of hypovolemia and shock, okay, up to CNS discomfort. Okay, so in order to treat this, basically is you're going to see this with me in 668 and 669 with me or other professor, that basically you would give chelation therapy in order to treat that. Is so treatment, in addition to that, you could give IV dextran. Okay, you could give solomedrol, dephenhydramine, which is Benadryl, or epinephrine in case of anaphylaxis. Okay, in addition, you could treat iron deficiency anemia with ferric gluconate. Remember that you have two types of form. You have sulfate and you have gluconate. And in case there is anaphylaxis with the IV dextran, is when you treat the patient with solomedrol, Benadryl, or epinephrine. And if there is any delayed reaction, 72 hours after, you could treat it the same way. Okay, so for overload and toxicity, you give chelation therapy. So this is very important for your exam and for practice. You have to make sure that you ruled out the most common cause, which is GI, by doing a stool YAC testing, which is a stool for cord blood. Okay. So this is basically to differentiate the types of anemia. You have the iron deficiency anemia. Both are microcytic. You have thalassemia and iron deficiency anemia. How do you basically differentiate this? You have the hemoglobin decrease, mostly in both. You have MCV decrease because both are microcytic. Okay. You have the red cell distribution width, which is the actual capacity increased, and this is normal in thalassemia. Transferrin will be decreased as a method of storage and transportation, okay, and it will be normal in thalassemia as well. Ferritin, which is storage, would be decreased in iron deficiency anemia and normal in thalassemia, as well as any receptor uh, uh, would be affected, but not in thalassemia. Okay, and everything will be kind of normal in anemia of chronic diseases, which is normocytic, normochromic. You have normal MCV and normal color. Okay, now let's talk about thalassemias. Basically, this is a group of inherited microcytic a hypochromic anemia. It's a hemolytic type of anemia characterized by defective hemoglobin synthesis. I understand that we already discussed that the normocytic normochromic could also include the hemolytic anemia, but this hemolysis is mainly due to sickle cell, for example. Uh, this disease is very particularly common in people that are from the Mediterranean, Africa, South Asian ancestry. The pathophysiology is that basically it's a hemoglobinopathy. Is one of the most common inherited disorder of the hemoglobin production. That's the reason why we're studying, even though it's very common in pediatric population. There is an unbalanced hemoglobin synthesis caused by decreased production of at least one globin peptide, which it could be beta hemoglobin, the alpha, or the delta. You have the alpha thalassemia and the beta thalassemia. Okay, so basically it's the reduced rate of synthesis of the globin, and there's a mutation for translocation of globin and destruction of the erythrocyte and the erythroblast. Okay, you have the beta thalassemia, which results from decreased production of the beta polypeptide. It's also autosomal. The carriers most of the time are asymptomatic or they have a mild to moderate microcytic anemia. Um, they could also develop if they have a beta thalassemia major, because you have the minor and the major, that develops severe anemia and bone marrow hyperactivity. Then you have the alpha thalassemia, which results from decreased production of the alpha polypeptide. Um, you have the heterozygote and the monozygotes. Uh, the heterozygote, they have a simple gene defect and are usually clinically normal, and the monozygotes, they develop mild to moderate microcytic anemia, but basically they have no symptoms. If the defect is in three or more genes, they have severely impaired alpha chain production, and that's when they continuously have blood loss, and they have increased morbidity and mortality. Okay, this is basically what I just explained already, and this is the molecule and the chains. You have the alpha, the beta, and the delta. This is the pathophysiology that I just explained already. It's just typed here for you. Okay. And again, if you have no mutation, only enough hemoglobin, you're basically the carrier, you're monozygote, and you have only one gene mutation, you might be a carrier without illness. Or if you have two mutations, you could have beta thalassemia major with severe anemia. So basically, if you have the both parents that are they have the thalassemia gene, you could have a normal person, offspring, or you could have a trait. You could have a patient that is carrier, or an offspring fully ill. Okay, this is again, you have 50% a chance of being a carrier or a trait, and 25% of being healthy and or having the thalassemia major. So basically, this is an hereditary disorder. It's also a type of hyperproliferative anemia and microcytic hypochromic, okay, that affects again Mediterranean. Okay, and this is again what I just explained. There's a block in the production of the beta chain or the alpha chain, that basically there's underproduction of the hemoglobin A, okay, that produces anemia. There is the precipitating factors that could produce trapping in the reticular endothelial cell and produce hemolysis, or in the bone marrow they could produce an ineffective erythropoiesis. The anemia of thalassemia, because there is hemolysis involved. Remember that when you have hemolysis of the hemoglobin molecule, you have inside the molecule of iron that converts into bilirubin. So patients could have iron overload, even more when they're exposed to transfusion. So you have to be very careful, because these patients with thalassemia, in difference with the iron deficiency anemia, the iron level is low. But the thalassemia, the iron level is normal to high. So if you give transfusion to these patients, they could go quickly into iron overload. It doesn't mean that you don't give it, but you have to be very, very cautious, because you could lead the patient into iron overload toxicity and have risk for cirrhosis of the liver, CNS disorder, metabolic acidosis, and even hypovolemic shock and pancreatic failure. Because these patients are in constant hemolysis. Remember that the spleen is not only a secondary lymph organ, but is also in charge of getting rid of the old and malformed red blood cells. So the spleen is going to be constantly active, working to get rid of those cells that are destroyed. So patients can go into splenomegaly and also autosplenia and hypersplenism. In addition, not only patients would have hemolysis, but all the components for the erythropoiesis will be affected. So they could have folate acid deficiency as well, in addition to their hemolytic anemia. Okay? So you have the splenomegaly that this patient has, and all the major complications related to that, all the encapsulated microorganism infections. Patients could get septic shock as well. So what will you see in the laboratories for thalassemia in difference to iron deficiency anemia? You're going to have the same decreased hemoglobin, decreased hematocrit, and decreased MCV, and decreased mean corpuscular hemoglobin concentration. But remember that iron deficiency anemia would have a high, would have a high TIBC and a low ferritin, but these patients would have a normal TIBC and a normal ferritin level that could also get into increased iron and iron overload. So basically, you would do an electrophoresis of hemoglobin to diagnose the disease, okay, by doing a gene test, okay. So basically, this disease is suspected in patients with a family history of it, subjective of signs and symptoms of microcytic hemolytic anemia. If thalassemia is suspected, laboratory tests for microcytic anemia should be done, the same panel. Okay. Um, you could also do quantitative hemoglobin studies. Um, you could do a bone marrow examination as well to exclude other causes of erythroid hyperplasia. You could do x-rays that basically show chronic bone marrow hyperactivity, cortical thinning of the skull, widening of the diploic space, appearance of the trabecula as a sun ray. Patients would have as well in the long bones uh, cortical thinning and osteoporosis, granular ground glass appearance in the vertebral body because of, remember, the bone marrow is in hyperactivity due to hemolysis. Okay, the therapy is sometimes splenectomy because remember these patients go into autosplenia and excessive working of the spleen um, because it's it's in charge of getting rid of the all red blood cells that are hemolyzed or malformed. Sometimes RBC transfusion and chelation therapy. So people with alpha and beta thalassemia minor require no treatment. Splenomegaly may be helpful if hemoglobin H disease causes severe anemia and splenomegaly. Children with beta thalassemia major should receive a few transfusions as possible to avoid iron overload. However, suppression of abnormal hematopoiesis by pure RBC transfusion may be valuable in severe affected patients. So you could do it, but you have to do it with very high caution. To prevent or delay iron overload excess, iron or excess transfusional iron must be removed. And how do you basically do that? By chelation therapy. And it's exactly the same treatment for iron toxicity. So again, if you have a patient that has iron toxicity, remember that the most common symptoms will be first epigastric pain associated with hypovolemic shock, um, including hypotension, tachycardia, diarrhea, nausea, and vomiting, and even metabolic acidosis. And how will you basically treat that? By chelation therapy, and the most common use is the furoxamine. In addition to that, we already explained about transfusion very, very carefully, splenectomy. Remember, very, very important, all the patients that receive a splenectomy should be vaccinated for capsulated microorganism, and that includes the Haemophilus influenza, the meningococci meningitis, uh, the the Neisseria meningitis, um, the streptococci pneumonia, and that's the most common. You could also, in addition, you could do hydroxyurea and stem bone marrow transplantation. Now let's talk about macrocytic anemia, which the most commons are the folic acid deficiency and vitamin B12. Remember that these are the macrocytic normochromic. Remember that hyperchromic does not exist. Okay. In addition, you could have this by antiviral drugs, chemotherapy. Remember the alcoholics, and liver cirrhosis. Patients that have hypo and hyperthyroidism, patients that have COPD. But again, these are the two most common that we will discuss. So basically, it's an ineffective hematopoiesis that affects all cell lineages, but particularly when you see a peripheral smear, you would basically see the macrocytes that are very enlarged, um, that are called megablast. That's the reason why it's also called megaloblastic anemia. The etiology, we already went through it. Pathophysiology, it basically results from, one second. So, again, this pernicious anemia is the macrocytic normochromic. Basically result from a defective DNA synthesis. RNA synthesis continue, resulting in a large cell with a large nucleus. Also has a big cytoplasm greater than the nuclear maturity. Um, could also cause anemia, deficiencies in vitamin B12 causes neurological manifestations, as you could see, including peripheral neuropathy, dementia, subacute combined degeneration. Patients could also have, in addition, combined folate deficiency. So whenever you see a patient with pernicious anemia, which is vitamin B12 deficiency, it's very good to treat these patients with folic acid as well. What you will see in the laboratory values are increased MCV uh, with a normal mean corpuscular hemoglobin concentration. The vitamin B12 level will be less than zero point 0.1, and they would have the Schilling test or intrinsic factor would be diminished. Remember that intrinsic factor is the factor that is present in the stomach with the acidity of the stomach that participates in the absorption of vitamin B12. So patients have deficiency of intrinsic factor. These patients could also be patients that have gastric bypass. So the antibody against the intrinsic factor will be positive. Treatment is basically replacing the vitamin B12. So any times secretion of gastric intrinsic factor is diminished, you get malabsorption of vitamin B12. Patients that have pepsin activity be reduced as well, they could have it. So you also would like to tell these patients that to eat food high in vitamin B12, which are mollusks, the clams, the fortified breakfast, cereal, liver, all the organs, salmon, milk, eggs. So you could basically give intranasal or intramuscular vitamin B12. That remember to be able to deplete vitamin B12 takes months to a year. So that's exactly how much you would like to replenish the storage. It could even take lifetime. So it's basically 1000 micrograms IM daily for a week, followed by 100 to 1000 micrograms weekly for a month, and then monthly for life. Okay, so any patient that has gastric bypass, you must suspect vitamin B12 deficiency or pernicious anemia. What you would basically would like to do for monitoring is reticulocyte count. Remember that hemoglobin and hematocrit would be diminished. The iron level would be completely normal, should not be affected, but folic acid, it is diminished, and vitamin B12 as well. So do that prior to treatment. Most likely the treatment will be combined, so vitamin B12 and folic acid. You must do also liver function test every 2 to 4 weeks because this vitamin B12 could be hepatotoxic. So basically, teach the patients about that this disease process is lifelong. It doesn't happen, replenish right away, and monitor what I just said. Then we have the folic acid deficiency, which is also a macrocytic normochromic type of anemia. Due to folic acid deficiency is most commonly due to inadequate intake or malabsorption of folic acid. Um, Most common symptoms are fatigue, dyspnea, unexertion, pallor, headache, the same as the other. What distinguishes this one from vitamin B12 is that there's no neurological signs seen. Um, this is the main difference. Laboratory values are more or less the same. You have macrocytic normochromic, so the MCV will be elevated and the mean corpuscular hemoglobin concentration will be normal. And of course, the serum folate will be 6 to 20, will be decreased. Now, basically, what you have to do is replenish. So you give folate 1 milligram orally every day. Um, foods high in folic acid, such as bananas, peanut butter, fish, green leafy vegetables, and also fortified cereals as well. Um, Remember that folic acid is very important for neural tube formation. So deficiency of this in pregnant women would have neural tubal defect. Um, Monitoring basically is to follow the hemoglobin and hematocrit in 4 weeks and then regularly. So this is a case that is you have to determine if it's vitamin B12 or folic acid. This is a 44-year-old with a non-history of alcoholism. There you have an evidence already of possibly vitamin B12. Presenting to the clinic with complaining of fatigue and difficult concentration at work. He says that he gets 8 to 10 hours of sleep per night, but never feels fully rested. He's not on any medication, and besides he's alcoholic, he has no significant past medical history. You have a normal sodium level, normal potassium level, normal chloride. Bicarb will be normal, BUN normal, creatinine normal, glucose normal, CVC, hemoglobin is 9.3 low, hematocrit is 27.7 low, WBC is 6.4, platelets are 249, and MCV is 113. Remember, it's 80 to 100, so you have a macrocytic type of anemia. Okay, so even though I'm not giving you values of neurological deficit, this not fully rested night could be due to restless leg syndrome, that is a sign of neurological defect or peripheral neuropathy. It could be sleep apnea as well. It could be any type of insomnia, but that could be related to restless leg syndrome as well. Okay. Um, so basically, the best step in management is to do the rest of the values, the laboratory. So you could do the whole anemia profile, including folic acid, to see if it's also diminished, and treat conjunctive in conjunction with it as well. In addition, you could do laboratories such as homocysteine level, because high levels of homocysteine will also affect vitamin B12 absorption. Okay. Now, normocytic normochromic anemia, the most common is acute blood loss, not chronic, because chronic, remember, is microcytic, and anemia of chronic diseases, even though in the classification could be a plastic anemia. Remember, normocytic normochromic, you're bleeding profusely enough that the bone marrow hasn't had the time to react and realize that there is anemia, or it has had time enough to compensate with chronic diseases, or because the bone marrow is not working properly with aplastic anemia or hemolytic anemia. So now let's talk about sickle cell disease. You have here a hemolytic type disease that basically is also hemoglobinopathy that causes chronic hemolytic anemia and occurs almost exclusively in blacks. It caused by homozygote inheritance of hemoglobin S. Remember that there's sickle-shaped RBCs that clog the capillaries, causing ischemia. It's not a thrombi formation, but the accumulation of sickle-shaped RBCs obstruct the blood capillary. That produces acute exacerbation of crisis and infection as well with bone marrow aplasia, and can give you long involvement with acute chest syndrome, and could be fatal as well. It's a normocytic type of anemia, hemolytic. Basically, the diagnosis is by electrophoresis. Okay, so you have it's a microvascular vaso-occlusion because all the sickle cells that or drepanocytes clog the capillary, causing any type of vaso-occlusive disease that produces pain and ischemia. This ischemia could happen at the level of the spleen, producing infarction, retina, liver, bone, CNS, and even in the pulmonary artery, causing acute chest syndrome, or in the fingertips, producing dactylitis. The precipitant factors that you must correct, and you must have this in mind for your test and clinical practices, the most common is dehydration. So you must hydrate the patient very well in order to avoid sickling. Think about infections, so you could basically do CVCs and cultures and treat the patient empirically. To avoid infection or treat infection, because it could continue triggering sickling. Fever, hypoxia. So look for the etiology of the possible decrease of SpO2 and treat it as well, and giving oxygen to the patient. And extreme exercise also could produce it. Diagnosis is by electrophoresis. And basically, talking a little bit about pathophysiology, remember that in hemoglobin S, valine is substituted by glutamine. Oxygenated hemoglobin S is much less soluble than oxygen hemoglobin A. It forms as a semi-solid gel that causes RBC to deform into a sickle shape in the presence of low oxygenation. Distorted, inflexible RBC adhere to vascular endothelium, and that blocks the arterioles and capillaries. That leads to infarction. So venous plugging predisposed to thrombosis. So any acute exacerbation produces a crisis, and that occurs intermittently. Patients have real pain. It's not that they are addicted to pain medications. Complications of this crisis could be from priapism, because they could also be clogged into the arteries of the penis. Long consequences could be splenic autosplenia and autodestruction and sequestration of the spleen, being susceptible to anaerobic encapsulated microorganisms such as pneumococci, salmonella, producing osteomyelitis. Other could be ischemic stroke. They could have CNS vasculitis, a vascular necrosis of the hip, renal failure, heart failure, pulmonary fibrosis. The diagnosis, again, it could be by DNA testing, it could be by hemoglobin electrophoresis. This is basically to demonstrate the normal red blood cells and the sickling and how they clog, producing thrombosis and ischemia. Patients could have a vaso-occlusive disease in the bones and in the abdomen that is precipitated by the same factors, or they could have an acute chest syndrome, which very, very common, and the saturation of oxygen is less than 90%. They have irreversible occlusion in the pulmonary circulation that is not relieved by anticoagulation therapy. It's basically by avoiding sickling. Okay. So they could have priapism, retinopathy, even called lithiasis, avascular necrosis, pulmonary hypertension, neurological complications, infections at any level, and this is the most common: strep pneumonia, salmonella, staph aureus, mycoplasma pneumonia, haemophilus influenza. Patients could have a plastic crisis as well, and they could be infected with parvovirus. This is basically explaining again the pathophysiology. The endpoint is clumping of the sickle cells in the circulation, producing damage at any level in the organ, producing autosplenia and fibrosis of the spleen, producing sickling and anemia and all the signs and symptoms of anemia, producing hypertrophy of the heart and heart failure, and also proliferation of bone marrow, producing towering skull. Very high mortality. So patients would have alterations of hypoxia that leads to deoxygenation of hemoglobin S, and that changes the membrane into a most viscous and sickling, producing clumping and capillary occlusion, and producing all the ischemia and infiltration and ischemic organs. this is basically to explain that these patients tend to have the sickling, the adherence to the endothelium, the sludging, capillary destruction, metabolic acidosis, vascular injury, and necrosis. And the more sickling, the more the vicious cycle. Now, you have to target the main risk factors. So, hydrate the patient is very, very important. Um, Basically, avoid the complications, pain management, antibiotics, give oxygen. So target the triggering factors. Now, blood transfusion is indicated, but is basically when the hemoglobin is less than 8, and you have to be very cautious because the more transfusion, the more viscosity, and the more viscosity means high hematocrit concentration. That means dehydration, and that could trigger sickling. Hydroxyurea can be given as well. Hydroxyurea is basically increases hemoglobin F, which is the fetal, that reduces the sickling and decreases the painful crisis. In addition, decreases the acute chest syndrome and impedes or diminishes transfusion requirements. Um, you could also give vaccinations. Remember that these patients are exposed to more susceptible to encapsulated anaerobic metabolism, bone marrow transplant, gene therapy, magnesium, folic acid as cofactors for the erythropoiesis, and in addition, you could cover for fungal infection as well. Now, let's talk briefly about aplastic anemia. That's basically hypo functioning of the bone marrow. Is another type of normocytic normochromic that results in loss of blood cell precursors, causing hypoplasia that I discussed briefly at the beginning. Is a type of hyperproliferative anemia. Is there's bone marrow depression with pancytopenia, meaning that all the factors are diminished. You have anemia, you have leukopenia, you have thrombocytopenia, you have reticulocytopenia, you have neutropenia. Is the cause basically again chemicals, exposure to Benzen, radioactive therapy, chemotherapy, any viral infection, Fanconi anemia, which is an autoimmune disease. Okay, so basically, patient that has been receiving radiation therapy from cancer, for example, um, receiving a blood transfusion, um, they come in with the signs and symptoms of anemia, which are in general, but they have severe thrombocytopenia, petechia, ecchymosis, bleeding in the gums or conjunctiva. They have a granulocytosis. Um, it's highly suspicious of aplastic anemia. So basically, you give immunosuppressive therapy because it's an autoimmune disease. Is diminished of the bone marrow, and you have to avoid spreading of infection. How do you diagnose this disease? Again, by CBC and bone marrow examination. Remember that it's suspected if you have pancytopenia or WBC less than 20,000, or in other literature you could see um, 1,500, or platelets less than 40,000. In other literatures, you could see less than 50,000. You could do a bone marrow aspirate that you actually see the decrease in bone cellularity. You could do CAT scans and ultrasound basically to rule out other etiologies and other type of anemias. You could use chest x-ray basically to rule out infections that are complications of this disease, liver diseases, cofactors that could be deficient that participate in erythropoiesis. The treatment is basically you could give anti-thymocyte globulin, you could give anti-lymphocyte, you could give hematopoietic cell transplantation, cytokines, you could give corticosteroids such as prednisone. Um, you could give vaccinations and chelation therapy as well because it's a type of hemolytic anemia. Um, Now let's talk about Glucose 6-phosphate dehydrogenase deficiency. These are an X-linked enzymatic defect, very common in black population that can result in hemolysis after an acute illness or intake of oxidant drugs such as sulfa. Very, very common after ingestion of salicylates or sulfa. It's a disorder of the RBC metabolism. You have decreased glutathione leading to hemolysis. Hemolysis selectively affect older RBCs among affected black and among most affected whites as well, but it's very common in black population. Hemolysis occurs commonly after fever, after an acute viral or bacterial infection, or after diabetes acidosis. Less commonly, hemolysis occur after exposure to drugs. These drugs could be primaquine, salicylate, sulfas, nalidixic acid for UTI. Whether continued use of the offending drug leads to a compensated hemolytic state or lethal hemolysis depend on the degree of deficiency of this enzyme. Um, basically, you diagnose this by a glucose 6-phosphate dehydrogenase assay. Is considered in acute hemolysis, particularly in black females and males. Um, Anemia, jaundice, reticulocytes, elevated. Haynes body is very, very commonly present. Um, these are dead cytoplasms and denaturalized hemoglobin that are present in the peripheral smear. So basically, the treatment is avoidance of the trigger, which it could be these medications that we mentioned. It's self-limit. Um, you could see antibodies that interacts with the RBC. You could see IgG present. You could see antibodies that interact with the RBC at temperature with an IgM as well. You could do a Coombs test, which is direct or indirect. Basically, remember that this is the proteins that are bounded to the surface of the RBC that in presence of hemolysis are elevated. The treatment is basically to prednisone to give an IG, splenectomy, and as well you could give immunosuppressors, avoid cold temperatures, and plasma exchange. There are other drugs-induced hemolytic anemia that we kind of discussed. Sulfa is a big one. Amphotericin B, cephalosporins, for example. You could also do a Coombs test and an IgG that is present. Then we have the anemia of chronic diseases that remember that this is any type of chronic disease, including renal failure, including bone marrow that have leukemia, lymphomas, etc. Um, this type of anemia was thought to occur as part of a chronic disorder, most often infection, but it could also be present in rheumatoid arthritis, in cancer. Um, the mechanism basically is slightly shortened RBC survival that occurs either by chronic granulomatous disease or infection or reduced formation of hemoglobin by decreased um, levels of iron or by increased storage of ferritin. So in addition to that, the erythropoiesis is impaired because of decrease of erythropoietin. So in the presence of renal failure, for example, any intracellular iron metabolism that is impaired could produce this as well. Signs and symptoms is basically depending on the underlying disorder. And what you would do is that this is a normocytic, normochromic type of anemia as well. These patients would have low hemoglobin, low hematocrit. They would have an MCV will be normal and an MCHC will be normal. Now, they would have flexibility on the other values. Remember that one of the pathophysiologies is the intracellular iron metabolism that is impaired, so the iron level could be low with high storage and low total iron binding capacity. Now, if you measure, inflammatory mediators will be elevated and reticulocyte counts will be impaired because when the patient, for example, have leukemia or lymphoma or any type of aplastic anemia that is a normocytic pneumochromic, the reticulocyte, which is the mature cell indicating that the bone marrow is healthy, is not going to be released. Okay, so it could happen by malignancy, by renal failure, by inflammation, by infection. These are the laboratories that you have to look for. The MCV and the MCHC will be completely normal. Treat the underlying condition and give erythropoietin in the form of epogen. Transfusion as well could also be given. Is in addition, you could see the values of the ferritin will be elevated, low iron, and low reticulocyte count in the presence of other pancytopenias. So treat the underlying cause. You could also give cofactors that are important for erythropoiesis. That doesn't mean that it's a macrocytic type of anemia. Remember that iron, vitamin B12, and folic acid are cofactors for the normal erythropoiesis. And this is a summary of all the type of anemia and the causes, which there's no need to go through. And this is a table of comparison that you could also read and look that, for example, you have macrocytic, the two most common that we went through, the microcytic, you have the two most common that we went through. What are the laboratory values that you would find and the main differences? And this is the end of this presentation.